This is my esteemed colleague, Keri Halsema. She is going to talk to us today about AML, and I am thrilled. She's a nurse practitioner and a senior instructor here in the School of Medicine, practicing at the University of Colorado Hospital in the Blood Disorder and Cellular Therapies program. That was a mouthful, but she is a mouthful because she's so amazing. Keri spent a few years in research using bird brains as a model system of learning and memory before earning her BSN and MSN at the University of Pennsylvania, Philadelphia. Do you want me to say the year?
Go ahead.
In 2008. I changed that by 10 years. Keri started her NP career at the old University of Colorado Hospital at 9th and Colorado in the bone marrow transplant program. Then she spent several years at City of Hope's hematology oncology program before finally landing in the Rockies at the University of Colorado in 2013. Keri and several staunch colleagues have built a robust survivorship program. I'm included in that, staunch colleagues for the allogeneic transplant recipient within the blood disorders program. She actively contributes to the program's disease-specific committees, developing guidelines and promoting education. You can catch Keri's Book Corner contribution in APSHO's Advanced Quarterly Electronic Journal. But Keri's just awesome. Not only does she contribute to the field like hugely, there's nothing she will not do for a patient. It's truly remarkable. So thank you, Keri. Teach us about AML.
Why, thank you, everybody. I'm going to use this, I think. So thank you so much for inviting me. It's a great honor to be here. And I'm thoroughly enjoying this. It's a good conference. So these are my objectives. We're going to talk about the therapy for APL, talk about the differences in treatment strategies in treating patients with AML, those who are eligible for intensive chemotherapy and those who are not, and then also summarize some of the treatment options for these actionable mutations that we find in AML. These are my disclosures. I have no financial disclosures. I graduated from the University of Notre Dame in 1986. I predict that the Fighting Irish will go on to the national champions and be the national champions this year. And I will also be in South Bend, Indiana, watching Notre Dame obliterate the SoCal Trojans, who I hate with the intensity of 1,000 suns. So I'm super excited about my trip to the Midwest in October. So we're going to start out with a case study, and the focus of this presentation will be on acute myeloid leukemias in induction chemotherapy treatment. So here is our little lady. She's a young 32-year-old Spanish-speaking female. She has no significant past medical history, and she just thinks she has the flu or a little bit of a headache or a little bit of a belly pain, and she doesn't have a PCP, so she wanders into the emergency room and they take a look at her. She doesn't look too toxic. They draw a CBC. She has a low white blood cell count, 74% blast. She's anemic and thrombocytopenic, and they think, oh my goodness, this lady has something kind of significant going on underneath the surface there. And so because of her headache, they decide to get a CT scan. She's got a subdural intracranial hemorrhage and subarachnoid hemorrhage. And in the meantime, they also draw some additional labs, and they see that her D-dimer is quite high at 57,000. Her fibrinogen doesn't look too bad, and her INR doesn't look too bad, but she has obvious bleeding and some coagulopathy going on. They also grab a CT scan of her chest, abdomen, and pelvis now that they know that she has something more significant than just an upper respiratory viral infection, and they see that this right abdominal muscle looks inflamed, and she may have a myositis infection there. And so to sort of kick off this presentation, just like so many people before me today, we're going to talk a little bit about the hematopoietic pathway. And when we're talking about acute leukemia, acute myeloid leukemia, we're talking about the cells on the left-hand side of this grid. And so typically we're looking at these myeloblasts. I have to put on my big glasses here. Promyeloblasts, these erythroblasts, and these I'm sorry, I can't see. And these monoblasts that get stuck in their maturation process, divide and overwhelm the hematopoietic system there. And so when we're looking at these cells underneath the slide, I, like you, look at these and I think, oh my goodness, I am so glad I am not a hematopathologist or a pathologist of any description for that matter, because all these look, to me, these all just look like pretty kind of purpley blue pink dots on another background, and they're kind of pretty colors, but they really mean nothing to me. But if you're a hematopathologist, the slides at the top are acute lymphoblastic leukemia, slides at the bottom are acute myeloid leukemia. But if we kind of take a deeper dive and crank up our magnification here, again, I still look at these, and the guys on the left, these myeloblasts on the left, don't look too much different to me than the lymphoblasts on the right. But then we get a cartoon with some verbiage on it that kind of explains what the difference between AML and ALL is, but that's still too complicated for me. So I go to this, which is just looks like maybe your fifth grader or 5-year-old actually drew this. So on the left is a myeloblast, and this is what our hematopathologists are looking at in these peripheral blood smears when these patients come in with a brand new diagnosis of acute leukemia. So a myeloblast is going to have these multiple nucleoli within the nucleus. They're going to have a little bit more cytoplasm, and they're going to have these Auer rods and these cytoplastic granules in their cytoplasm. And that's how they differentiate myeloblasts from lymphoblasts. And that's when Dr. Shawinski, who's one of our very favorite hematopathologists, either emails us or calls us. Usually he calls us. He doesn't like to epic chat very much, is what he told me just this past week. And lets us know whether he thinks that this is a myeloid leukemia or a lymphoid leukemia, because that's important for us to know kind of up front and quickly. So here's our little lady again. She's still young and 32. She still had no other significant medical, past medical history. She still has a coagulopathy, and she still has some bleeds in her head. And at this point, we're thinking, because Dr. Shawinski called us up and said, I think this is a myeloid leukemia. We think that she has acute promyelocytic leukemia. APL is what we're going to call it going forward. And so we're going to do a whole bunch of stuff all at once, because we're very good at multitasking when somebody comes in with an acute leukemia and we're concerned about them. We are, since we're suspecting she has an APL, and we suspect that because her white count's not too high, she has a coagulopathy, and she has obvious signs of DIC. She's already bleeding. We want to start her on Atra pronto. Now, why would we want to start her on Atra pronto? Does anyone know out in my fine audience? What is giving somebody who has suspected APL Atra upfront do for us? What does it help us wrap our arms around? DIC, right? Because those promyeloblast, those cells responsible and causing all that high white count and those blasts in APL produce tissue factor, and that's what causes that cascade into DIC. So we want to start giving the patient Atra to help decrease and promote differentiation of these promyeloblasts, so they stop producing tissue factor, so we can stop DIC. We're going to do a bone marrow biopsy on this patient, but before we could even get to that, we're going to send some peripheral blood stat for FISH to look for this PML RARA gene, which is this translocation fusion gene, pathognomonic for APL. We're going to be sending next generation sequencing on this patient. We're going to work her up for cardiac issues. We're going to do an echo and an EKG. We're going to work her up for infection, cold infections that most people wouldn't kind of think about, but we oftentimes check for HIV and hepatitis in these patients, because they can show up with these occult infections that have never been treated. And now that we've got them in our warm medical embrace, we want to start treating them for this. We're going to monitor labs very, very closely in this patient. We're going to draw these DIC labs probably every 4 hours, looking at all her clotting factors. We're going to consider differentiation syndrome in this patient. She's got a low white count. probably not at real high risk for this. But we may or may not start her on 0.5 milligram per kilogram of prednisone to prophylax her against differentiation syndrome. And remember, she's got this belly pain that she came in with, and now we think she has this myositis. We're going to probably pan culture her and start her on some antibiotics. We're going to consult neurosurge, right? She's got a big old bleed in her head. We don't know whether this is going to get better, worse. Is she going to get more bleeds? We want neurosurge on our rapid call response and be there right by our elbow in case we need anything. And the one thing that, we don't want to neglect is social work and spiritual support for these patients, because a lot of times these patients come into the ED, they have had no support. They haven't had any medical intervention, maybe for most of their lives. And we've got to address some things for them because, again, she just wandered into the emergency room thinking she had a headache and maybe an upper respiratory viral infection. And now we're telling her she's got an acute leukemia. We're going to need to admit her, and she's going to have to stay for a few weeks with us. So again, this PML-RA mutation is this fusion gene caused by the translocation 1517. And what happens when this fusion gene is created by this translocation is that it stops the differentiation of these promyelocytes. What we've known for decades now is that this RA mutation, which is named for retinoic acid receptor, is that it binds retinoic acid. It changes the conformation of the PML-RA fusion gene and allows differentiation to proceed as it normally would. So in essence, by giving these patients retinoic acid, we promote differentiation. We actually start these patients on the road to cure with their APL. And we've known that for probably 20, 25 years at this point in time. If you look at the NCCN guidelines, the most recent ones published online, we stratify risk for APL based simply on their white count. So it could be a white count less than 10,000 is considered low risk. White count higher than 10,000 is considered high risk. And Our Lady has a total white count of about 3,000, and she's young and healthy otherwise, as far as we know. And so what we decide to get her started on, now that we know that she's got this PML-RA gene, we've started her on some ATRA. We're considering starting her on this Lococo regimen here. Now, this Lococo regimen really changed the landscape for the treatment of APL. And I want to make sure that you don't confuse the Lococo regimen with Coco Chanel, who is the fashion icon that brought, the luxury items that we now associate with Chanel to the American and general public. But this is the Lococo regimen that was published back in 2013. The Lococo group looked at ATRA because, again, we knew that ATRA was very effective in these APL patients. And they paired ATRA along with idarubicin, mitoxantrone, and methotrexate 6-MP, kind of a la some of our ALL regimens, and compared that to ATRA and arsenic trioxide. And basically, you treat these patients with these regimens, and then you check a bone marrow biopsy at about 28 to 35 days to see what sort of effect that you got. And this has proven to be very effective in these patients. And here are these Kaplan-Meier curves that are taken out of this 2013 study. And as you can see, if you use the eyeball test here, a couple of things I want to point out is that the overall response rate for both of these regimens is really pretty fantastic compared to a lot of our other regimens and our other hematologic malignancies, somewhere above 75% in this patient population, because ATRA in and of itself is so effective. But if we compare ATRA arsenic, which is the blue lines here, and we look at event-free survival, overall survival, and progression-free survival, those that receive the ATRA and ATO pass the eyeball test as being superior to patients who receive the ATRA with the chemotherapy regimen. And therefore, that is why ATRA and ATO has become the standard of care for these patients with APL. So here's our little lady. She's still 32 years old. We started her on ATRA. She got a couple of doses of ATRA, and then all of a sudden her white count went way up. Please note that her blast percentage didn't go down. It's still high at 90%. She's still got these head bleeds. We really think that she's got APL. And now she's got this higher white count and she has new onset hypoxia. And we're thinking that she may have this differentiation syndrome that a couple of us have touched on. And just to kind of drive home that point, differentiation syndrome is this rapid maturation of all these promyeloblasts. It does decrease that risk of DIC because these promyeloblasts are maturing out and not producing that tissue factor anymore, but it causes all this cytokine production with fever, fluid retention, hypoxia, pulmonary edema, and whatnot. And these patients can get real sick, real fast if you don't recognize differentiation syndrome. So here's our lady. She's sitting in the ED. Maybe she's found her way up to our floor, she's got this fever. She's starting to look a little bit puffy. Maybe her creatinine's beginning to increase. She's now on some supplemental oxygen. The things that you have to think about is that if the symptoms are real severe, you might want to stop the ATRA. In our program, we are such superstars at managing most of these things. A lot of times we hop on it real quick. We're able to recognize this really pretty quickly. We start steroids, high-dose steroids, dexamethasone, every 12 hours on these patients. We make sure that we're diuresing them cautiously, and if they need dialysis or supplemental oxygen care, we jump on that. So a lot of times we don't have to go ahead and stop the ATRA, and we can just kind of treat through. So we go back here to our NCCN guidelines. She was originally classified as a low risk because her white count was low, but now we've kind of pushed her up into high risk. Plus she's got DIC, plus she's got differentiation syndrome. I'd say that this lady has popped herself into this high risk category. And if we look at our NCCN guidelines, the things that we're going to want to do for this lady is we want to give her that ATRA and ATO, just like we would for almost anybody who shows up in our emergency department with APL. But we also want to add idarubicin because we want to bring that white count down. And we need some standard chemotherapy to help us do that. The thing I also want to point out is that if you don't want to use ATRA and ATO and some age-adjusted idarubicin as the preferred agent here in the NCCN guidelines, you have lots of other choices. If she's CD33 positive, you could have done your flow cytometry and maybe she came back positive for CD33, you can use gemtuzumab in her. Or you can use daunorubicin and cytarabine in this patient. So you can go through these guidelines so you're not just stuck with one regimen. You have the NCCN gurus have given us quite a few choices for treatment in these patients. So here we are. We've identified her with APL, where she's on ATRA, ATO, and idarubicin. We have started dexamethasone on her for treatment of her differentiation syndrome. Maybe or maybe not, we're using Hydrea on her. You could have thrown that on her 2 grams, maybe 3 times a day for that uptrending white blood cell count. Kind of depends on how fast she's going to be responding to the traditional chemotherapy that we're getting. But it's all things that you have in your back pocket, and you're watching this patient like white on rice in your unit. So here we are again. Here's our little lady. I've aged her. I put her in a time machine and I pushed her forward 30 years. So instead of, 20 years, instead of being 32, she's now 52. Okay. She's still Spanish speaking. She still shows up in the ED with a headache, abdominal pain, and fever. She still has those blasts and that high white count. She still has a bleed in her head. But look at here, we did some workup on her. Her EKG tells me that she has a prolonged QT at 550 and a very low EF. I don't know why. I don't know whether this is an acute event in her or whether she has congestive heart failure that has been undiagnosed. And I know from my NCCN guidelines and all the smart people that surround me at my hospital and clinic that I don't want to use arsenic in these patients with these prolonged QTs because of risk of sending them into a ventricular tachycardia. So for patients, APL patients that have some cardiac issues, again, we have options. So for patients with just a low EF, you can still use the arsenic trioxide. You can pair that with gemtuzumab if you like. But if you have a prolonged QT, you want to avoid the arsenic trioxide. And again, the other options that you can use in these patients is listed here. But please note that we never get rid of the ATRA. The ATRA is sort of that core piece of APL treatment in these patients. So here's our little lady. We've sent her back in time. She's now 32 years old again. She's still Spanish speaking. She comes into the ED. She's got fever, some upper respiratory symptoms, some drenching night sweats, a headache again, and she's got this rash going on. She doesn't look terrible to the providers in the ED, but they go ahead and they draw a CBC. They see she's got a high white count, 60% blast. She's thrombocytopenic and anemic. They see these numbers again, they say, oh my gosh, what's going on here? Let's scan her head because now maybe she's got a bleed in there. CT scan shows no signs of bleeding. She has no other signs of bleeding, and her coagulation studies don't look too terrible. D-dimer's a little bit elevated at 4,500, but she's got an acute leukemia. And so they call us up and they say, hey, we got this lady in the ED and her white count's high and she's got these blasts. We think she's got a leukemia. And I'm like, yeah, I think she's got a leukemia too, but I don't know what kind, but let's go ahead and find out. So we're going to go ahead and ask Dr. Shawinski to look at a peripheral blood smear for us real quickly. We're admitting her in the middle of the night, and I know that I'm going to get a bone marrow biopsy on her within about 12 hours of her landing in the emergency room. We're going to send stat next-gen sequencing, flow cytometry, and FISH on these people. I don't think she has APL. So I'm going to watch her for any signs of bleeding, but I don't feel compelled to start her on any steroid to prophylax her for differentiation syndrome at this point. And again, I go back to my little kindergarten drawings here, and Dr. Shawinski comes back to me and says, yep, those are myeloblasts in their care. They're not lymphoblasts. So I think she's got an acute myeloid leukemia. We do the bone marrow biopsy, and our fabulous lab people get all of our information back to us really, really quickly. We find with the flow cytometry, she's CD33 positive. We can use gemtuzumab for that. She's got FISH that's positive for this translocation 816, which is the most common Runx mutation there is. And she doesn't have a 17p deletion. So I don't think she's got TP53 mutation because of that. You can have some TP53 mutations that are not 17p deleted, but generally speaking, if you have a 17p deletion, you probably are TP53 mutated. So, and again, we're going to do all the things that we do when we're taking care of these people, look for occult infections like HIV and hepatitis. We're going to watch their labs real closely. Oh, we're going to prophylax them with tumor lysis, right? We're going to start them on allopurinol, maybe some fluids, and watch them real closely. So let's pause for a moment here. When I start thinking about these really sick patients that come in that didn't even know they were sick an hour ago, like we just told them, like, oh my gosh, you were so sick. I start to think, I want to look at them and I want to think about what their risk is. And that's really determined a lot by these molecular markers, what their fitness is, how well do I think they're going to be able to withstand aggressive chemotherapy, and whether they have any of these actionable mutations. So next-gen sequencing is something that I think a few people have touched on. You can kind of think about it as PCR on steroids. You're able to screen for many molecular mutations all at once, not knowing what you're looking for. And highlighted here in yellow are some of our common myeloid-associated mutations like the IDHs. I forgot to highlight FLT3 right there, but it's sitting right there. TP53 and RUNX. And if you're into MPN1s, because, you know, we all like all myeloid stuff. Like, we're not going to just pretend that people don't have other mutations as well. These also screen for all the JAKs, CALR and CXCR4, which are commonly associated with NPNs. And so then we go back to our guidelines to kind of figure out what this patient's risk is. So this patient has this translocation 821, which is that common RUNX1 mutation. And that kind of puts her into that favorable risk category. And then you're going to say, but Keri, there's what about this RUNX1 down here? What's that all about? How come it's a good risk up here, but it's a bad risk down here? And that's because there's different isotypes for these mutations. So the one that's the translocation 821 is good risk. The other ones, the other RUNX1 mutations confer bad risk for these patients. And when I think about fitness, this is a nice little graphic here that, you know, our goal is to get them to complete response, right? And if you're a hardy Coloradan, you don't care. You're going to climb up that really steep hill and get up to the top through intensive chemotherapy. But some of our patients can't manage that, even though they're natives to the Denver area. Maybe they're older or they have multiple other comorbidities, but we can still get them to the top of this CR hill by treating them appropriately, okay? So something to think about. In many of these studies, they use this old criteria that can kind of conceptualize patient fitness. So you want to think about, you know, whether they have multi-organ comorbidity, so lung, liver, kidneys, that sort of thing. Are they older? And as I'm getting older, the age 75 doesn't sound too old to me, because that's only 15 years away for me. Do they have cognitive impairment regardless of their age? What is their performance status? You know, one of the things that we like to say here in Colorado, he's a fit 95-year-old, you know, and we do see some 95-year-olds that are bicycling every day, and they're not using e-bikes. They're using your traditional road bikes. They hike, they're very, very active, and they've been active and fit all of their life. And then there's this sort of catch-all term that any other comorbidity that the provider deems that the patient would be not able to withstand high-dose chemotherapy, intensive chemotherapy. So here's our little lady again. She's 32, so she's young. She doesn't have really any comorbidities that we're able to pick up on. There's her counts. And we think, based on all of this, we think we know she's got a CD33 positive AML with this favorable RUNX1 mutation. So let's go back to our NCCN guidelines. How are we going to treat her? We're going to treat her with this, and she looks like she's in good shape. We're going to go ahead with intensive chemotherapy for her. We're going to give her that standard 7+3. So daunorubicin or idarubicin for 3 days, cytarabine continuous infusion for 7 days. And because she's CD33 positive, we're going to add on that gemtuzumab to the chemotherapy regimen. And the data that supports this is this clinical trial that came out in 2012. And the gemtuzumab arm, along with 7+3, is in the red lines here. And the control group is essentially patients that just received 7+3. And these Kaplan-Meier curves very obviously pass the eyeball test. You can see that those patients that received the GemSAR did better with regards to event-free survival, relapse-free survival, and overall survival in all categories here. And so that led to the designation of this as a preferred agent for these patients that are fit for intensive chemotherapy and also have that CD33 cell marker. And so here we are back at our little lady. So we know she's got myeloblast, she's an AML patient, she's got this a good mutation, this RUNX1 mutation, but now we've found that she also is positive for this TP53. Our next gen sequencing panel came back a day later. Our fish also came back with some extra mutations. She's got 5q minus in version 3 and this other translocation. So now she's got some markers that make me concerned that she's a young, fit, high-risk patient. And so what can we do for this little lady? So here are her mutations here. So we know that she's got high-risk disease. And we look at our NCCN guidelines. And again, 7+3, it's great stuff. We use it all the time. It is very effective in treating these patients. But let's say you are concerned about giving her 7+3, or she can't, for whatever reason, you decide you want to give her something different. So you could give her 7+3 with mitoxantrone. You can use FLAG-IDA, which is fludarabine, Ara-C, and idarubicin along with GCSF. You can include venetoclax. There are many options for these patients in these NCCN guidelines. So it's not just one regimen that you would need to choose for this patient. And here we are again. Here's our case study here. So our patient, I've again aged her by 40 years. So I put her into a time capsule and shot her 40 years ahead of time. And now she's got known cardiovascular disease. She's got paroxysmal AFib. She's got bad diabetes. She was a smoker most of her life. And now she's got COPD on chronic oxygen. And by the way, she's still smoking. And it makes you nervous because she's smoking around her open oxygen. And you think she's going to cause an explosion for you, yourself, everybody in the ED, as well as on your floor. She's still got a high white count. She's got 60% blasts. She has no head bleed. Again, Dr. Shawinski says, oh, this lady's got AML and she's got all these bad markers. Now, what are we going to do? She's an older, frailer lady with multiple comorbidities, and she's got high-risk disease. What are we going to do? So we go back to our NCCN guidelines. Here are these available therapies for this patient that is not eligible for high-intensity chemotherapy. And generally speaking, it's a hypomethylating agent, either azacitidine or decitabine paired with venetoclax. And the reason that this is a good regimen is based on this 2020 study that was published by DiNardo and company. And we knew that these hypomethylating agents, either azacitidine or decitabine, were very effective in acute leukemias prior to the study coming out. But if we pair this with venetoclax, we see that these patients that are not eligible for this high-intensity chemotherapy tend to do much better, as this Kaplan-Meier curve points out. So you're probably thinking to yourself, like, Keri, I want to make sure that this patient's, getting all the good chemotherapy that I can give her. She's a nice lady. She's 74. Yeah, she's got a bad heart and she's got, she's on oxygen and everything. But, shouldn't we just give her 7+3 and roll the dice and see what we come up with? And maybe we can just support her because we're superstars on our floor with all of our supportive care. But what I want to point out is that this chance of remission is not predicated and dependent on just giving this high intensity chemotherapy. People can go into remission with venetoclax and a hypomethylating agent, or venetoclax with low dose Ara-C. And our group here at University of Colorado actually published data on this. And this is looking at patients in the blue received high-intensity chemotherapy. Patients in the red were treated with azacitidine and venetoclax. And if you look at on the left here is overall survival in these groups, and on the right is progression-free survival. And if we look at the top here, we see that all comers, all ages, all types, the people that get the intensive chemotherapy tend to do better, right? They have a better response. But if we tease out those patients that are a little bit older, have higher risk disease, and in this case had possibly a transplant, we see that these patients that fit that criteria tend to do better. So we know that these patients that probably shouldn't be getting this high intensity chemotherapy respond really well to what you would consider this lower intensive chemotherapy, hypomethylating agent, either azacitidine or decitabine paired with venetoclax. Now, what is this venetoclax that you speak of, Keri Ann? Well, I will tell you. Venetoclax is a small molecule that binds to the this family of proteins called BCL2 proteins. And these BCL2 proteins interact with mitochondria that keep the cells from dying. So it's an anti-apoptosis protein. And when you add venetoclax, it stops that anti-apoptosis effect, and the cells go on to go ahead and apoptose and die. This is a very effective treatment. And so one of the things you want to watch out for real closely is this tumor lysis risk. And just as Glenn wasn't lying to you when he said, when you're starting venetoclax on somebody, your goal is to get that white count down less than 25,000, because that risk of TLS goes way, way up when that white count is high. So do whatever you can. You have to put them on the apheresis machine and suck out some of those white cells. Go ahead and do it. You want to pair that with some hydrea. That's totally fine. Give them maybe a little bit of other chemotherapy. That's fine too. Get that white count down. You want to admit these patients for the dose escalation of venetoclax, and that's all outlined here, because you want to sit on them. You want to be drawing their TLS labs every 4 hours, every 6 hours, every 12 hours, depending on what you think their risk is and what their electrolytes look like. And you want to just sit on them to make sure that they don't get into trouble, okay? So here's our lady. She's still 72. She still has multiple comorbidities. There's her counts again. We know that she's got AML, but instead of having TP53, she's got these mutations. IDH1 or IDH2 or FLT3, okay? So let's talk about these. So these are those actionable mutations, and these have really modified how we're thinking about treating these patients now, because these are very specific mutations that we're able to take advantage of if we have the appropriate inhibitor. So for the FLT3 inhibitors on the NCCN guidelines, there's actually 4 of them on the market right now. Midostaurin is identified within the NCCN guidelines, recommended in the NCCN guidelines for FLT3 positive for induction chemotherapy for patients that are going to get intense chemotherapy, ivosidenib, which is our IDH1 inhibitor, and these can be combined with 7+3 because these patients are young and fit, and we want to give them a specific inhibitor in addition to their chemotherapy. Quizartinib was just FDA approved for FLT3 TKD, right? I always do, yeah, TKD mutation. Oh, I'm sorry, ITD, it's right there, ITD mutation, and it hasn't yet made it onto the NCCN guidelines, so stay tuned for that. And for patients that are not eligible, like our 72-year-old little lady with bad heart and bad lungs, we still have the ability to use these inhibitors and pair them with possibly azacitidine and venetoclax or as single agents. The same is true with the FLT3 inhibitors. So let's take a look at these a little bit more. So these FLT3 inhibitors are tyrosine kinase inhibitor. Tyrosine kinases are those secondary messenger systems within the cell that tell cells to either divide or not divide. And by when patients have this FLT3 mutation, apoptosis is halted. These cells continue to divide until we give them an inhibitor. So it's like double negative. So we tell them to go ahead and apoptose, and the patients and the cells go through their normal cell cycle. So we have sorafenib and midostaurin are those first generation FLT3 inhibitors. And when we look at the use of these, not so much in the upfront therapy, but then relapsed disease post-allo transplant, we see that patients receiving these inhibitors do better than patients receiving placebo or standard of care regimen. And gilteritinib and quizartinib are our second generation or a new generation FLT3 inhibitors. The same holds true. Patients getting these inhibitors tend to do better and respond better than just regular salvage chemotherapy. Things that we're going to look out for with these is QT prolongation and the risk of ventricular arrhythmias, differentiation syndrome. And then if we look at these IDH inhibitors, these have to do with methylation, interrupting the methylation of DNA. So DNA needs to be methylated in order to be turned on or turned off for transcription. And so what IDH mutation does is that it interrupts this methylation process. And so the DNA is either not being transcribed or being transcribed inappropriately, causing cells, these blast cells, to continue to divide. We throw in an IDH inhibitor into the mix, and this dysregulation of DNA methylation is put to rest, and cells can then cycle through their normal cell cycle. And this slide is a nice sort of summary of many clinical trials looking at the use of these IDH inhibitors, either ivosidenib, which is an IDH1 inhibitor, or enasidenib, which is an IDH2 inhibitor. You get some response there. But if you go ahead and pair either ivosidenib or enasidenib with azacitidine, our favorite hypomethylating agent here, you get a much better response. So if you give the patients a little bit of chemotherapy with their IDH inhibitors, they do much better. And then, of course, here in the middle is this green highlights that azacitidine and venetoclax still gives you the best response in all of these groups. So again, we're going to be looking for differentiation syndrome and QT prolongation, just like we were with the FLT3 inhibitors. And then sort of the newer sort of idea of inhibition is this menin inhibitor. And menin is a protein that is found in AML that has NPN1 and this KMT2 mutation. And these types of leukemia are very dependent on this HOX and MEIS1 protein transcription in order to promote leukemogenesis. And if you block menin with this SNDX 5613, which actually has a name now, and I'm blanking on it right now, you allow the cells to go forward with their regular go down their differentiation cascade, the blasts disappear, and you allow the cells to mature, and you help cure the patient's leukemia. And overall, we're getting a very good response in these patients with this new idea with this menin inhibitor. We actually have one of the clinical trials here on our campus that we use. And that is all I have. Here's all my references. And I thank you for that. And that's it. After azacitidine venetoclax, or can we give everybody azacitidine venetoclax, get them into a CR, and skip 7+3? Well, we can, that's short answer is I don't know. I don't think anybody knows. I would think that there are some patients that are not going to want to go to transplant, right? And we all know that if we just treat all comers with azacitidine venetoclax, get them into CR, one of the things that we find is that we get them into CR, they don't stay in CR for very long. There's that high risk of relapse. So we have better outcomes, longer outcomes, and much more data, decades of data with 7+3 compared to azacitidine and venetoclax. There's a lot of chatter and expert opinion being published on just that idea that maybe 7+3 has seen its day, and we're going to be getting rid of that because now we've got all these other inhibitors that we can use in our back pocket. We've got CAR-T, we've got all of those tools, as opposed to just blasting people with this high intensity chemotherapy. But I know that you think that we're going to be doing away with all the traditional cytotoxic agents. I think there's going to be a place for them. I think especially, I don't know that much about the pediatric regimens or the pediatric space in any hematologic malignancies, but, kids seem to do much better with the high intensity chemotherapy than us old folks do, even if the old folk is only 21 or 22 years old, right? So I don't think cytotoxic agents are going to go away. I think their use is going to be much more refined and specific for a patient population, especially in the adult treatment. But good question. Anybody else? Thank you very much, everybody. Thank you.